We have seen the machine, and now these machines, the flow sensors, what sir talked about, and the pressure sensors, they are going to generate a certain numbers, certain diagrams, waveforms, and we need to understand those things. We have seen the technology, and it is going to generate a certain amount of picture. You will have certain loops, you will have scalars, you will have numbers, you will have this tidal volume, minute volume, your PEEP, and various types of pressure, especially with the newer anesthesia workstation. It is very important for us to understand. You see a ventilator screen, almost 70% of the ventilator screen is occupied by the graphs, isn't it? And we conveniently ignore those graphs and we just concentrate on the numbers, isn't it? The company has given it for a purpose. We need to be familiar very much. Or even agar aap basic bhi anesthesia workstation ki baat kare, so almost all of them will at least have two scalars. So it's very important that we are familiar with the this thing. So what I'm going to do is, I'm going to finish it in 20 minutes. I will talk about need for mechanical ventilation. We'll talk about principles, nomenclature, and I'll stop my talk at the scalars. We won't be able to talk about the loops at this point of time, but let's see if we can do, and that also we'll talk about the common scalars. Indication for mechanical ventilation, no breathing. हम लोग रोज करते हैं ये. We paralyze the patient, we sort of create a no breathing stage. Breathing not enough. We have given a deep sort of anesthesia, not breathing. I need to support him. I'm not saying about invasive or non-invasive, but I need to support that ventilation. He is breathing enough, but is not meeting the goal, that is hypoxia or hypercapnia. As simple as that. So basically, two aspects of your mechanical ventilation is insufficient oxygenation and insufficient alveolar ventilation. Mind you, these are two different processes, isn't it? Oxygenation के लिए हम लोग SpO2 की बात करते हैं. As मॉर्निंग का जो हम लोगों का टॉक था, वी कन्वीनियंटली इग्नोर द कैप्नोग्राफी पार्ट ऑफ इट, द ETCO2 पार्ट ऑफ इट. अगेन द रीजन इज पल्स ऑक्सीमीटर 1500 का है और कैप्नोग्राफी 1.5 लाख की है. सो बट दैट्स नॉट अ रीजन, है ना. एज सर वाज सेइंग, इट हैज बीन मैंडेटरी इन द आइडा गाइडलाइंस एंड वी नीड टू गो बियॉन्ड द कन्वेंशनल थिंकिंग एंड नीड टू हैव दिस थिंग. So benefits of mechanical ventilation, it improves the gas exchange and decreases the work of breathing. Now this is very important for all of us to understand. VQ ideally, that is ventilation perfusion. जो alveoli में मेरी air जा रही है, उस alveoli को नीचे से जो blood supply लेके जा रहा है, वो match करना चाहिए, and that is what we say VQ will be 1. जहाँ पर आपका VQ है, where your alveoli are collapsed, that is the place where your ventilation will try to open it up and will try to create some sort of thing. So it is useful for shunt, not for the dead space. Okay? So now sir talked about various flows, pressure and volume. Especially for postgraduates, we need to understand these three important concepts. So there is some similarity between a lung and a balloon. So what happens is, you see there is a pressure which is generated by a ventilator, isn't it? A ventilator, as the four technologies sir talked about, it's a pressure being generated. Ultimately, that pressure, what will happen is, it will result in a flow being created. A flow will be created. That flow will occur right from the ventilator. It will pass on to the circuits. That it will go through your endotracheal tube. Ultimately, it will reach your bronchus and will expand your tidal volumes. That the lung in the volume will change, and that is what we call as volume. So three important terminologies, जो 3 ग्राफ हमको दिखते हैं. Pressure, that is which is generated. Second is the flow which is created by this thing. And the third thing is the volume, that is a change in the tidal volume which happens, isn't it? So basically in this particular example, the ventilator is the kid's lungs. They are acting as a ventilator, isn't it? It's generating the pressure. His airway is acting as the circuit to create into this thing. The initial part of the balloon, the starting ka part, that is also acting as your trachea or endotracheal tube. And ultimately the tidal volume, पहले आपका गुब्बारा छोटा था, now it has expanded. That's basically a tidal volume change. So it's quite a simplification, but these three terminologies becomes very important. Pressure, which can be generated by person, by bag, as sir was saying, ambu bag is mandatory. Ventilator. The next thing is the flow is created, and then ultimately there's a change in this thing, and which is called as a tidal volume. So pressure, flow, and volume, the three graphs which will be seen onto this thing. Now let's talk about little bit about compliance and resistance. We all need to understand this thing. It's a very straightforward thing. लेकिन आपके machines में खास करके new workstations में you will have this compliance, you will have this resistance, static compliance and dynamic compliance. So what are these things? Let's talk a little bit about lung mechanics. So respiratory system, when we talk, it's a mechanical system of lung exchange. There are two elements into this thing. So if I'm giving a mechanical power, I need to overcome two important things. One is the initial resistive element, and the second part is the elastic component. The resistive elements is predominantly basically आपका जो conducting system है, that is your resistive element, and the elastic system is basically your alveoli and the things which have a tendency for expansion and to recollapse. This is very important for all of us to understand. So two elements. So basically endotracheal tube, airway, and you will have your lung and chest wall. These two important things. Now, basically, if you look at the resistance, resistance is nothing but the definition of airway is basically change in the transpulmonary pressure needed to produce a unit of flow of gas across the airways of lung. It's very important to understand this thing. So what is happening is, suppose there is a pipe. I want to create a flow. ये A point है और एक B point है. If I have to create a flow across A to B, there is a resistance which is going to be offered, and I need to overcome that resistance. So that is basically nothing but a resistance. So basically, you can have natural and artificial airway. हमारा ट्रकिया है, ब्रोंकस है, these are our natural airways. You have endotracheal tube. से आप इसोफेगोस्कोपी करा रहे हैं मैलिग्नेंसी के लिए, 8 नंबर की ट्यूब आप यूज कर रहे थे और अभी नॉर्मल पेशेंट्स में, और अभी इस पेशेंट में आपने मान लीजिए 5, you have used a 5.5 tube. Your resistance has increased despite the same setting, isn't it? So that is something we need to understand. So the formula is change in pressure divided by change of flow. कितना मेरे को pressure versus flow. It's very easy to remember. So ultimately, if you look into the formula, how do I calculate the pressure which is required to overcome this resistance? I'll have to see how much flow I am requiring and how much resistance I am requiring. If my resistance increases, my driving pressure increases for overcoming. If I am increasing my flow for whatever reason, मेरे को ज़्यादा respiratory rate देना, I need to increase my flow. Again, ultimately your resistive pressure will increase. Clear cut? So this is the first component of it. Now look at the second component. Compliance. It is more easy to understand, isn't it? A healthy lung, a pneumonia lung, and an emphysema lung. Suppose you have to give 500 ml of tidal volume to these 3 lungs. This will probably expand in only say 10 centimeters of water. This same lung, which is having some fluid, ARDS है, आपका pulmonary edema, it will probably require 20 centimeters of water to create the same 500 ml of tidal volume. So the lung is, this is a more compliant lung and this is a less compliant lung. An easy example is a postgraduate. आपके पास में साल में 5-10 postgraduate आता है. There are compliant postgraduate and there are less compliant postgraduate. एक को आपको बोल, see, PGs are easy target, okay? Tomorrow you will also be doing the same thing. So what happens is we can push everything in the name of postgraduates. ठीक है, 5 PGs हैं, suppose एक यूनिट में, एक को आपने एक बार काम बोल दिया वो फटाक से मान लेता है. It's a compliant thing, isn't it? दूसरे को आपको 4 बार बोलना पड़ता है वही काम करने के लिए. मशीन टेस्ट करो, सवेरे के ड्रग्स बनाओ. So it takes certain amount of time. I'm trying to speed up here. ठीक है? So compliance and elastance is basically from the lungs and chest wall. Again, important for us to understand the chest wall. आपका patient burns का है ना? आपका patient ARDS का है, बहुत ज़्यादा fluid दिया है. Actually, the chest wall compliance becomes very important. ठीक है? So volume and stiffness becomes very important. So compliance is nothing but change in tidal volume by change in pressure. 500 ml का tidal volume लगा, 20 सेंटीमीटर का मेरे को प्रेशर लगा. द कंप्लायंस इज 500 डिवाइडेड बाय 20, दैट इज 25 ml पर सेंटीमीटर ऑफ वाटर. क्लियर? 1 ml का अगर मेरे को एक्सपांड करना है तो मुझे 25 ml जो है एक प्रेशर में लगेगा. नाउ इफ द सेम थिंग फॉर 500 ml, इफ यू आर रिक्वायरिंग 40 centimeters ऑफ वाटर, योर कंप्लायंस हैज गॉन डाउन बिकॉज 500 डिवाइडेड बाय 10. सो दिस इज बेसिकली द थर्ड एस्पेक्ट ऑफ दिस, isn't it? So ultimately, we talk about equation of motion. Now, even this is more important in your ICU, but as an anesthesiologist, even before I talk about spirometry, it's very important that we talk about driving pressure. तो हमने दो चीजें देखी. So what drives the ventilator? The first one was the resistance and the second one was the elastance component. Now the resistive component was flow multiplied by resistance. Distensive component was tidal volume divided by your compliance. So ultimately if you look into this thing, आपका ventilator को जो driving pressure है, it is multiplication of flow, multiplication of resistance and how much tidal volume. You increase your tidal volume, more pressure will be required, and compliance goes into your denominator. If you are having a good compliance, you will require less amount of pressure. If your compliance goes up, automatically your this thing goes up. ठीक है? And ultimately, what is the pressure? Muscle plus ventilator. What happens in anesthesia? We sort of give muscle paralysis, so this becomes 0. So all the pressure has to be provided by the ventilator. In ICU, what happens is, slowly when we are weaning it off, we are sort of trying to make it 0 and try to convert it to muscle. So this is something very important for us to understand. Okay? So this is pressure, it's measured in centimeter, flow is measured in liters per minute, very important, and volume is measured in ml per minute. So this is the three things which we are going to talk about, and let's see the three graphs, okay? So we have inspiration, you have expiration. What changes from inspiration to expiration is called as the termination, and what changes from expiration to inspiration is called as the trigger, isn't it? And target is something inspiration mein. For example, if it's a pressure control ventilation, your target is when I achieve a 20 centimeter of volume. In volume control, your target is, say, volume. I have given a 500 ml tidal volume, that is what I'm going to give. See, so that becomes very straightforward. Now, coming to the anesthesia machine spirometry. So you can have two important things to look into. You can have look into the numbers, and you can have to look into the graphs. So for example, you can look into your tidal volumes, your curve leak test and leak around the tube. You can talk about the minute ventilation and your targets. In the pressure, we talk about the P peak, P plateau and P mean. I'll come to this thing. But very important that we talk about at least driving pressure. All of us should be slowly familiar with the driving pressure. What is driving pressure? What is driving pressure? अभी तक हम लोग क्या करते थे? High P peak pressure हो रहा है, so we were more concerned. Then we said, okay, let's talk about P plateau. कि P plateau ज़्यादा हो रहा है तो then है. But we sort of conveniently ignored कि अगर मेरा P plateau में I am using a 15 का PEEP, that is different from a patient. You're getting two important things. I'll give you two examples. Two patients are there, and both of them are having a plateau pressures of say 30. Okay? But in one patient, your PEEP is almost around 5, and in second patient, your PEEP is almost around 15 to 20. Now, both of them are having a P plateau. The conventional definition was P plateau. But now, if you look at the driving pressure, that is nothing but P plateau minus PEEP. So we have to ultimately rely on that thing. And now more and more people are slowly talking about mechanical power. Mechanical power is still difficult to get into your routine anesthesia machine, but driving pressures is something which is going to be there, and we need to be very clearly available about. Okay? Scalars. So we'll talk only about the scalar. That is the last part of the presentation. What are scalars? जो आपको वेंटिलेटर के स्क्रीन पे दिखते हैं, they are all scalars. Flow against time, that's a flow scalar. Pressure being plotted against time, breath to breath, that's a pressure scalar. And when you have volume being plotted against time, that's a volume scalar. So that becomes very important. So you have this pressure time scalar, you have flow time scalar, and you have a volume scalar. So now let's talk about loops. Commonly available loops are pressure volume, flow volume. Very important. This is not yet the feature which is available in anesthesia machine, but we understand that it will come. We should be very important, especially all of you must be working in your ICUs. We should say no to auto scaling. Why? आपके यहाँ पे क्या ratios है ICU में doctors का, nurses का? See, at our place it's, I can't tell it openly, but it's not good. ठीक है? You have one doctor and you might be having 8 to 10 patients who have been seeing these patients. ठीक है? Nurses का भी है. You cannot keep on looking at everything. So you rely on the ventilator screen. कंपनी ने वेंटिलेटर स्क्रीन में जानबूझ के दिया हुआ है. अगर आपने उसको ऑटो स्केलिंग पे रखा तो यू वोंट बी एबल टू डिटेक्ट द चेंजेस फ्रॉम फार. से एग्जांपल, पेशेंट है मेरा, अभी उसका एयरवे प्रेशर वॉल्यूम कंट्रोल पे मैं उसको वेंटिलेट कर रहा था, 400 ml ऑफ टाइडल वॉल्यूम, आई वाज गेटिंग अ 20 प्रेशर. फॉर सम रीजन इफ द ट्यूब हैड ब्लॉक्ड, okay, so now my pressure has gone to 40. So what will happen is you'll start seeing big graphs onto the ventilator. Even from far you can identify something is wrong with the patient. But the moment you do it on auto scaling, what will happen is that number, that graph will automatically adjust, and you will still see कि हाँ graph तो अच्छा ही दिख रहा है. So if you set at a fixed scale, what will happen is, even from afar, you will be able to identify that certain things are wrong, isn't it? So if you are in ICU and if you have a ventilator which says no to auto scaling, you should use it. The standard would be, say, set a pressure of around 40, 45, 50, set a flow of say around 100 के आसपास में, and set a volume of tidal. कोई भी चीज अगर आपकी कम या ज्यादा हो रही है, just by seeing the graph height from afar, you will be able to identify. अगर आपने उसको auto scaling कर दिया, आपका ग्राफ क्या करेगा? उसको बढ़िया से उसको टाइट्रेट करेगा, and from afar you won't be able to identify. This is something we expect that it will be coming into your anesthesia machines also. Okay, we'll not talk about the mode and everything, but जहाँ पे आपका square waveform होता है, that is basically your type of ventilation. So अगर pressure time scalar है and you see a pressure scalar as a square waveform, it's basically a pressure control ventilation. Now let's talk about प्रेशर स्केलर के यूजेस क्या क्या है करके, ठीक है. इट कैन बी यूज फॉर एयर ट्रैपिंग, ब्रोंकोडायलेटर रिस्पॉन्स एंड ऑल दोस थिंग्स, एंड दीज आर वेरी इंपॉर्टेंट इवन फॉर अस इन एनेस्थीसिया. Forget about the ICU part of it. This is something which is required for day to day also, isn't it? So this is what a pressure scaler looks like. Here can you see 5? It's a 0, 5. So this is basically a set sort of PEEP of 5. Okay. Now the patient is taking breath. This is a peak pressure. This is sort of a plateau pressure, and he is coming here. Now the patient has tried to breathe. So he is trying to trigger a response. So that is why जब हम trigger करते हैं तो आपका pressure dip होता है. So this is basically a patient effort which you are able to identify on a pressure scaler, isn't it? So I'm not going to go into detail, but this is basically your peak pressure and this is your plateau pressure. The rough idea is a peak pressure corresponds more or less to your resistive elements, and plateau pressure is something which is seen towards the end of your this thing, and it corresponds to your alveoli. हम लोग जो ज़्यादा चीज़ों के लिए interested है, that is the plateau pressure. Now let's see two diagrams. It will become very important. Now what you see, this is a, suppose imagine this is a normal graph, the dotted line. Okay, what do you see here? A peak pressure has gone up, but can you see the plateau pressure? It is same. Can you appreciate this difference? Peak pressure has gone up here, but the plateau pressure is more or less same. So the peak pressure is 60, plateau is 15. So probably what is happening is some of your resistive elements are creating a problem, and it can be anything. I'm not going to go into troubleshooting, but the easiest way, as sir was also saying, अम्बू बैग आपके पास होना चाहिए. अगर आपको नहीं समझ में आ रहा है कि मेरा पीक प्रेशर किससे बना है, डिस्कनेक्ट द सर्किट, ठीक है. डिस्कनेक्ट करने के बाद में अम्बू बैग करिए. इफ यू फील इट्स अ रेजिस्टेंस इन योर अम्बू बैग, द प्रॉब्लम इज डाउन द ट्यूब, ठीक है. एंड इफ यू थिंक कि अम्बू बैग सब कुछ सही था, मोस्ट प्रोबेबली योर प्रॉब्लम इज अपस्ट्रीम, दैट इज प्रोबेबली समवेयर इन द वेंटिलेटर. इट्स अ इजी वे. नाउ द सेकंड एग्जांपल आई कैन से शो टू यू इज, okay, can you appreciate this thing? Your peak pressure and your plateau pressure both has gone up. Can you appreciate the difference between these two diagrams? The peak pressure is here, the plateau pressures are same, but in the second diagram, if you can see, your plateau pressures have also gone up. So this is representing something wrong with your alveoli. So this is something which has to be really concerning for me. Either your patient is having pulmonary edema or ARDS or whatever it is there. You need to look into the causes. So this is basically decreased compliance. I have set a PEEP of 5. This is how you detect auto PEEP. But you see my PEEP is getting up. For whatever reason, your patient is getting into a auto PEEP. The next is pressure scalar. Now I'll talk about the flow time scalar. Again, flow में आपको वॉल्यूम कंट्रोल में इट्स बेसिकली द फ्लो विच विल बी अ स्क्वायर वेंटिलेटर. सो सपोज आपके ऊपर में वेंटिलेटर का वेवफॉर्म नहीं भी रखा हुआ है, मोड नहीं रखा हुआ है, स्टिल इफ यू आर एबल टू सी कि जिसका स्क्वायर वेवफॉर्म है, दैट इज द प्राइमरी मोड ऑफ वेंटिलेशन. यू कैन डू दिस टेस्टिंग टू योर न्यू जूनियर्स, विल बी कमिंग इन अ कपल ऑफ वीक्स आई थिंक, है ना. यू स्विच ऑफ द मोड, ट्राई टू मेक देम आइडेंटिफाई कि कौन सा मोड है. इफ दे आर एबल टू आइडेंटिफाई प्रेशर वर्सेस वॉल्यूम, द फर्स्ट टेस्ट दैट इज दे अंडरस्टैंड व्हाट द स्केलर्स आर एंड हाउ डू दे लुक लाइक, ठीक है. So flow time scalar, what can be used for? Again, auto PEEPing, airway obstruction, bronchodilator response, inspiratory flow, asynchrony. So I'll just give you an example. ये आपका flow है. So this is your inspiration nicely going down. This is your expiration. This dotted line is supposed to be a normal one. It is touching the baseline. जितना आपने air दिया था, whatever air you had given to the patient, all of it has come out. Now what is happening is, in your there is some amount of air which is still not touching the baseline. So that air is getting trapped into the lung. And even before that, your next tidal volume has started. For whatever reason, आपका patient शायद time cycled है and it's not able to do this thing. Over a period of time, what will happen is this air trapping slowly over a period is going to cause a auto PEEPing. So you will be able to understand auto PEEPing कहाँ पर हो रहा है. Especially if you are having this in anesthesia, you should be able to correctly rectify it as to why it is happening. Okay? So is this concept clear? Air trapping or auto PEEPing. Now this is a bronchodilator response. Now can you see this is peak expiratory flow rate. It was going slowly and a long expiratory time was there. Now after a bronchodilator, you can see it's going very nicely. You need to be very clear that you can have a shorter T also in ARDS patient. आपके lung compliant ही नहीं है. आप जितना air देते हैं उतना ही rapidly they push it out. So you need to look all these things into the clinical context of the patient. कि patient मेरा किस type से कर रहा है. So response to a bronchodilator becomes very important. ठीक है. Again, this is very important. Inspiratory time and expiratory time, how much you are setting. This is an inspiratory pause. ठीक है. So your inspiratory pause is a good thing. When you do an inspiratory pause, it helps for your diffusion of oxygenation. But मान लीजिए इस inspiratory pause के साथ में you are having a nice expiratory pause, it is touching baseline, all good. But if it was causing an auto PEEP, you need to consider, can I cut down on my inspiratory time? So see, this is something you will be only able to understand if you see the graphs. It is something which you won't be able to see from the IE ratio ka numbers, okay? Airway secretions, we always understand this thing, okay? Especially nowadays with HME filters, this is less of a problem. But if you have an ICU patient, and especially you have water traps connected with this thing, this can become a real problem for us. Now the last thing is volume scalar. Volume scalars are comparatively found less on anesthesia machines, but in a newer machines you will be having them, and this is how they look like. Your inspiration, if it's an inspiratory pause, you'll have a pause, and your volume returns back to normal, okay? Now the majority problem is loss of volume. Can you see this thing? Inspiration and then your expiration. This becomes a big problem for anesthesia. Especially agar hum low flow anesthesia ki baat kar rahe, if I am getting 100 ml of leak and I am not able to understand it, and then it's of no use, because whatever you are doing, it's causing a big amount of leak, isn't it? So understand this from the scalar. The second way to understand is VTI and VT. As sir was saying, there are two sensors nowadays in most of the modern anesthesia. VTI is inspiratory tidal volume, and VT will be your expiratory tidal volume. So if there's a big gap or difference between these two, that means somewhere down the line you are losing your volume. Now this is again a problem, air trapping. Can you see this is a flow scalar? Which type of ventilation is this? If this is a flow scalar? Volume control, good, because it's a square waveform, okay? So you can see a lot of air trapping happening. Why the air trapping is happening? Why I'm saying it's a air trapping? Because it's not touching the baseline. So if you see correspondingly to your lung volume, you see this lung volume will slowly start going up, and there will be a lot of loss. This is classical scenario for your acute asthma. You keep on doing pumping in the air, you don't give time for this patient, your patient will collapse immediately. See, you have been called in emergency department, acute asthma ka patient hai, intubate karna hai. You intubated the patient. Aapne intubate kiya, 2-4 minute ke baad mein you suddenly notice the patient had got into cardiac arrest. The reason, one of the reason might be you are ventilating it like a normal patient, 10 to 12 ka breaths you are keeping, the air was just being pumped inside, nothing was there, it is like a tension pneumothorax. One of the easiest ways, disconnect the tube, you will see a lot of gush of air coming out. You need to understand the treatment. Ventilator is not the treatment for acute asthma, you need to use bronchodilators and treatment, and then ultimately it will work, okay? So,
sir, what is your thought on expiratory pause? Like, suppose if it is too long, shall we reduce the inspiratory-expiratory ratio? Because, you know, many times expiratory pause being too long is also a problem. So
completely.
That is how 1:2, which is a very common scenario. The evidence says that we should keep 1:1 or 1.5, because expiratory pause being too long is also a problem.
Completely agree, sir. And there are two things, aspects to it, and we will further add to it, sir. One is the next talk, what we are talking about is the lung protective ventilation. And one of the important things what we talk about lung protective ventilation is atelectasis. And it's a severely underappreciated complication of anesthesia. When you keep a expiratory pause and without an adequate PEEP, you are tending to cause some amount of atelectasis. So that becomes a problem. So whatever you are sort of achieving with a lung protective ventilation, partially you are negating with it. Secondly, as we sir said, this has been the traditional teachings to us. 1:2, 500 ml ka tidal volume, 2+2, 4 liter ka flow rate, and this has been like what we have been doing. So over a period of time, we need to change our thought. It has to be an individualized ventilator setting. For example, you get a patient, exploratory laparotomy, perforation ke saath mein hai, acidosis hai, and he's trying to compensate his metabolic acidosis by hyperventilation. You intubated the patient, and now you have kept a respiratory rate of 12. So on top of your metabolic acidosis, you are creating a respiratory component. So again, that IE ratio becomes very important. You cut down on your respiratory pause, and this becomes. So look at the patient, look at the surgery, look at the background as to why we are ventilating the patient, and then based on that thing, I think inspiratory, expiratory time, the pause and everything needs to be handled. Auto PEEPing, again, we need to look for the cause of auto PEEPing, sir. Most of the time, the auto PEEPing causing is because, as sir was saying, IE ratio becomes very important. If you are giving an expiratory time which is not sufficient, 1:2 is not a magic number. First and foremost, I think the thing I would like to say is there is nothing like a fixed 1:2. You can change it as per the patient. Second thing is, what drugs whichever we are using, they are all in a tendency to cause some amount of bronchospasm. As sir was saying, we are bypassing our natural humidification mechanism. We are using dry gases, and that too not at a low flow, at a 2 to 4. So some amount of you are expecting bronchospasm or something. That small bronchospasm is going to cause you a lot of auto-peeping. Over a period of time, it will keep on increasing. So one of the easiest ways, you can look at your bronchodilator. If there is a resistive component, endotracheal tube की वजह से हो रहा है, your HME filters, unfortunately, I mean, like we should not say, sometimes it happens your HME filters are not changed over a period of time.
Completely blocked at the start.
Completely blocked. We look at everything and we are like, patient, badhiya hai, what is happening? And your HME filter, and the easiest way is take out your HME filter. Wait it. All the postgraduates, when you should put the HME filters. As I said, sir, probably one of the important thing is disconnect it, do an ambu bagging. Your hand is still the best thing. As sir was pointing out in his talk, it's not the machine which is problem. It's we are not able to understand or appreciate that thing. मेरे को अगर बैग बढ़िया फील हो रहा है, डाउन द लाइन प्रॉब्लम नहीं है, प्रॉब्लम इज अपस्ट्रीम. और अगर मेरे को पेशेंट में मशीन में अम्बू बैग के साथ भी प्रॉब्लम हो रहा है, इट्स नॉट अ प्रॉब्लम विद द मशीन, प्रॉबेबली समवेयर डाउन द लाइन. सो दैट इज द वेरियस वेज वी कैन लुक इनटू.